All right, we're live. Teri, I'm so happy to have you here. Welcome, everyone. It's to our Friday Facebook Live segment, Caring Conversations, where we look forward to bringing topics that are relevant to our clients, their families, our caregiver teams, and our healthcare partners. My name is Julie Collada, and I am the founder and CEO of Open Arms Solutions. And Open Arms Solutions is a home care company where we proudly provide a professional care team of caregivers and care coordinators to help seniors and their families navigate the challenges of aging and illness, and proudly supporting their dignity and independence in their own homes. With me today is the famous Teri Dreher, the founder and CEO of Nshore Patient Advocates. Teri, well done. I would go into any, I was going to say tough situation with you and figure it out when there's a time deadline, and I could just envision you in the operating room in a hospital, calm and cool, and figuring things out to get it done. And I'll fill in the viewers on that topic in just a moment. Our topic today is things to consider when selecting a skilled nursing facility for your loved one, and obviously very important topic that at some point in our lives, most of us will have to, deal with that topic. So for those of us that are joining us this morning, if you have a question, please feel free to ask and type it into our chat area. And I'll be checking that throughout the broadcast, and we'll do our best to answer those questions. So for those of you that are listening this morning, we had some technical challenges, and we were kind of counting it down to see if we could make this all happen live. And through some very cool and collected work by Teri and our ever faithful and talented Sarah, we made it happen. And I'm really glad that we did. So Teri, to start us off, would you please tell us about yourself? Tell us about the journey that ultimately got you into nursing, and then ultimately to found Nshore Patient Advocates.
Well, sure. Thank you, Julie. It's so wonderful to be here. Thank you. I appreciate the privilege of being able to talk to your audience today. And this is a really important topic. It's always been a really important topic, but during COVID times, I think it's even more critical. My past career history is mostly full of being an intensive care nurse, not only in New England, but also in the Chicago area and Denver and all over the country. I just loved intensive care, and I thought I'd do it forever, honestly, because I love the real holistic mind, body, spirit support for one or two clients or patients at a time. I always really loved that, but around 2010, I started to see a lot of changes in healthcare that I wasn't a big fan of, and little red flags started going off in my head when all the changes in our country started, meaning that doctors and nurses were spending a lot more time on the computer and paying more attention, honestly, to the computer than the patients. Intensive care nurses used to spend maybe 10 or 15% of their time on the computer documenting things, and the rest of the time on patient care. And within about a year and a half, we actually did some studies in our unit and found that doctors and nurses were spending 2/3 of their day on the computer, and they were not spending as much time assessing patients thoroughly, or giving emotional support or education. A lot of hospitals did away with their hospital education departments for patients because they said education doesn't pay. And a lot of things just started happening that didn't make sense to me. And about that time, our family had a crisis. We were on a cruise in Belize for my in-laws' 50th anniversary, and my father-in-law had a life-threatening event on board a cruise ship, and me being the ICU nurse, I jumped in there and did what I needed to do to save his life. And that was 14 years ago, and he's still alive today. But he went through probably 12 to 14 near-death experiences over 6 weeks. He almost bled to death. He had terrible allergic reactions. We had to flight him back from the Caribbean to Chicago. I saw a lot of near misses due to poor communication. And again, nurses and doctors paying more attention to the computer. A few weeks after my father-in-law got stabilized, and he's still alive today, I was almost fired for strongly advocating for a patient that I really loved, her and her family. And she was having a lot of complications from a really big surgery. And the doctor was being very laissez-faire about figuring out where the bleeding was coming from. And when I questioned him, he got very defensive and almost threw a chart at me. And the next day, he transferred the patient out of ICU. And later that afternoon, the daughter came running up to me and said, "Teri, mommy's going to die. Her blood pressure is 60/30. She's laying in a puddle of dark red stool. You have to do something." So I knew I could get fired by doing what I did, but I pulled her into a side room and said, "Tiffany, if this was my mother, this is what I would do." And I told her what to do, and we sprung into action. I called administration of the hospital, and that doctor, my head nurse, threatened me. She said, "God help you if you have done something, to warn the family about this." And I said, "Well, it's the right thing to do." And so that was a big light bulb. All of a sudden, it was kind of telling me that healthcare is different now. And average people don't even know the right questions to ask. They don't know when to stand up. They don't know what patient rights really look like on the ground. And so the doctor tried to get me fired, and it made me so mad. I went out and took a course on being a patient advocate. And in 2011, I launched Nshore Patient Advocates, which is now the largest, highest skill level professional advocacy company in Chicagoland. And last fall, I started a nonprofit company called Seniors Alone, guardianship and advocacy services to protect and guard and take care of lower income people. So that's it in a nutshell.
Teri, I love when I ask that question because I've known you through the years. We just had an opportunity a few times to see each other at different industry events, but I never knew. That's an amazing story.
Well,
that is a wonderful story.
Thank
you. Boy, I'm sure your father-in-law is grateful that his son married you. That is a really, really wonderful story. So, patient advocate, you've done a great job of describing an example of a patient advocate, and we are seeing more patient advocates in the area.
Mm-hmm.
There's also another category that in senior care we've heard about more traditionally, and geriatric, and that is a geriatric care manager. And I know that I have been since I've been in the industry for now going on my 13th year, that we work with many geriatric care managers and families. That's a very well, I think it's been around for a longer period of time. People overall may be more familiar with what that is. I think it might be very helpful to the people that are listening to just for you to share from your perspective, what's the difference between a geriatric care manager and for those of you that may not know what a geriatric care manager is, a geriatric care manager is often it is a nurse or social worker or someone, maybe someone that has a master's in gerontology. It doesn't always have to be, but it often is. And the way I think about a geriatric care manager is that they they can be incredible value to families when there is not an adult child or family member that is either available locally or they may be available locally, but just through their own circumstance, just don't have the time to be there for their loved one. Not that they don't want to be, but they just, they just aren't able to be. And so a geriatric care manager can really step in, and sometimes I've heard them considered to be, like it's the oldest daughter, the advocate, like an older daughter would be, but with more training and background. And so that's kind of a very high level idea of a geriatric care manager. So what's the difference between that and a patient advocate?
Great question, Julie. And I want to start off by saying I have nothing but the highest regard for care managers. They used to be called the American Geriatric Care Management Society, and it's called the Aging Life Care Association now, which is made up mostly of community care managers. And I am a certified care manager, a CCM, and I love ALCA, and I'm a member of the Care Management Society of America too. So I am also a care manager, and I really respect the time that industry has been ongoing, probably for about 25 or 30 years, as opposed to patient advocacy, which is only about 10 years. The real crux of how the whole field of patient advocacy came about is because of a growing concern over medical error in this country. And really, it's gotten no better since all of the safety guards were put into place with Obamacare, because it really takes doctors and nurses away from the hospital. So every patient advocate will give you a different definition, but my simple definition of a patient advocate is somebody that stands in the gap. We're more like the Secret Service. We're kind of a cross between an advanced practice nurse, a lawyer, and Sherlock Holmes. So for instance, I got a client yesterday who's been through a 6-week nightmare at a hospital, and he got transferred to a long-term acute care hospital yesterday. He's developmentally disabled. So it's my job to go through all of his labs, talk to all the care providers, talk about the plan of care, develop a really comprehensive care plan, and virtually figure out what's really going on with this gentleman. And his brother hired us. We get hired by family all over the country. And our model is very similar to community care managers. We're all privately paid. Care managers in the hospital have a completely different role. Hospitals really hire them to get people in and out of the hospital as quickly as possible. But right now we have a really blossoming group, a demographic in our country called senior orphans, people that don't have any family, or they have no family close by. And so I would say probably 75% of our client base are senior orphans, or were hired by people that are out of town or frustrated. And sometimes older people get grumpy, they don't feel good, and then they start fighting with their family. And oftentimes it's better for the family and the patient if a nurse advocate comes in and manages the care, because we're a little bit more objective. There's not all that family dynamic stuff. And it allows the adult children to carry on with their families and do their own job, because caregiving in the community is more and more complex. People are sicker outside of hospitals right now. And today everybody's trying to avoid hospitals. So coming from intensive care, I had no idea what the community looks like, but it's like the Wild West out there. And we fight for patients' rights and safety all the time. So I guess we're very similar to care managers, but we do a little bit more fighting because we're experts on patient rights, and we protect patient rights and safety, and we know where the gaps are in healthcare and how to avoid those dangerous and costly gaps.
So, and that's a great explanation, and that's really helpful. It sounds to me like when you say we really fight, you have the knowledge to identify
Mm-hmm.
where there's what you call a gap,
Mm-hmm.
right? You have the knowledge that I would think that many geriatric care managers don't really have the training. The gap in really specific, doctor's orders, right? So when you're really talking about is the doc doing the right thing? Are the right meds being prescribed?
Mm-hmm.
I think incredibly important because
Mm-hmm.
most of us, and I will put myself in the same category, although my mom was much more of a trailblazer in this regard. My mom was the inspiration behind Open Arms. She was tough. Most of us, and I really, we listen to our doctor and we nod our head.
Mm-hmm.
We don't challenge. We don't ask questions.
Uh-huh.
We assume that they are the experts and are making decisions for us in their best interest. And I think gratefully most of the time that they do, but I think I've learned since I've been in this world of healthcare, sometimes they miss things. They're human beings.
Yeah.
Right. And I really appreciate and respect that there's someone like you in your organization that will step in and not be shy about really understanding is this being done the right way. So really well done. Obviously we can use our whole time just to talk about this topic, and we've already used almost 20 minutes of this, so thank you. But I think it's a really important information for people. So let's just jump right over to the topic, which is things to consider when selecting a skilled nursing facility for your loved one.
Mm-hmm.
When you say skilled nursing,
Mm-hmm.
can you define that a little bit more for people that are listening? Because there can be a broad services that are provided in a skilled nursing facility.
Right. Well, most of the bedside care and help with activities of daily living in skilled nursing facilities are ultimately provided by health aides. Some of them are certified nursing assistants, which means they've gone through a 3 or 4 month program at a college, but mostly it's custodial care. But skilled nursing facilities have to have skilled licensed RNs on staff 24/7. And most skilled nursing facilities are part rehab facilities and part long-term care skilled facilities. So just say, you're an 82-year-old woman who is a professional, never got married, never had kids, don't have any siblings, nobody to take care of you, and you develop multiple sclerosis, and eventually you lose your ability to walk completely. And so if you're wheelchair bound or bed bound, you probably cannot live in an assisted living community unless you're really adept with your wheelchair. But MS sometimes comes along with some cognitive changes in later stages. So if people need things like wound care, IVs, somebody 24/7 to give them medications, doing assessment of them, and things that only a nurse can really do, then you need to be in a long-term care skilled facility. Medicare will pay for probably 2 or 3 weeks in most cases of rehabilitation. And usually the rehab floors in skilled nursing facilities are the ones with the pretty wallpaper and the decorating and the nice carpet on the main floor. And boy, families walk in and they see that and they're like, oh my gosh, this is great. But often they don't ask, can I see the long-term care unit? And the long-term care unit usually doesn't look too much like that. And so things are different in COVID right now, but the really sad part for all senior communities is the isolation, of restrictions. And even in memory care facilities right now, with the numbers going up, people that thrive on social contact are spending most of their day in their rooms. If they do come out for meals, they have to sit at a table all by themselves. And they don't have access to family, and it's heartbreaking. But let's talk a little bit about how you assess. One of my best frontline tools in the Chicago area is chicagonursinghomsearch.com. Just
Okay.
Google that, and they color code all the skilled nursing facilities, all the senior communities in Chicagoland by different colors. Like I think red is the worst, green is the best, and yellow is sort of 4-star.
ChicagoNursingHomes.com.
No, ChicagoNursingHomsearch.com.
ChicagoNursingHomeSearch.com. Sarah, are you able to put that up so people can see that?
It's a great resource, and a bunch of computer geeks down at Mather put together this website. And what they're basically doing is taking the star ratings, the Medicare star ratings of all nursing homes, and rating them. Now, keep in mind that most of the ratings are self-reported, but if there have been a lot of reports from the Illinois Department of Health on violations or illegal activities in that nursing home, all nursing homes need to keep a log of every complaint that's ever been made. And so if a family goes into the nursing home and they're looking even virtually, they have to have access to all the reports. The Illinois Department of Public Health keeps records of all reports, whether the violation was fixed or not. And a lot of the criteria in there is also based on, the nurse-patient ratio. And I always ask that. Back in the old days when we used to go into nursing homes, I could smell what the place looked like. I would look at the linens and get a good sense of how well funded they were. I would ask how long the executive director has been there, because places that change executive directors every 2 or 3 months, that's a bad place. That means that the director of nursing and the executive director get in there and they find out, oh my gosh, this place is horrible. They ask for changes to be made and corporate says, sorry, we don't have enough money. And so then they leave. So this goes for all senior living communities, but it's especially true with skilled nursing facilities. You really want to pay attention to the infection rates, especially COVID. And again, the Illinois Department of Public Health keeps up-to-date records on how many COVID cases are in every facility. So people can go on IDPH and just Google all the different facilities, just go in their COVID rates. And so those are 2 things that you can do before you even talk to the people. Also, when you talk, ask about all the extras, because a lot of times skilled facilities will say, oh, yes, it's only, it's like $6,000 a month. Oh, but by the way, they're going to charge you for incontinence supplies. They're going to charge you for nurses to give medications. They're going to charge you for all kinds of other things. So just make sure you know what the monthly rate includes for long-term care. And compare that so you have apples to apples, oranges to oranges. Don't always take the word of your neighbors or your girlfriends for whether or not a nursing home is good or not. Always, go to Chicago Nursing Home Search, look at their infection rates, look at the reviews online, and just narrow it down to 2 or 3. A lot of times families try to choose a place that's close in location, but I say that's one of the least of the factors, because this is going to be your loved one's new home. So if you have to drive an extra 15 minutes to get to a quality facility, that's a loving act, going out of your way to do that. So those are a lot of the things, but I always want to talk about staff turnover, because that's a real red herring for any facility, because if the staff aren't happy, then the patients aren't going to be happy. I had a client in one nursing home facility that one day every single one of the CNAs called in sick. That's a place that was
a problem.
Yeah. It was terrible. Terrible.
That is really tough. Yeah. And that's really all really good advice and great questions to ask. Is at what point do you know what's the risk benefit versus a nursing home? How do you assess, is it a better decision for my loved one to be, I want to keep them home, they want to stay home, but at what point do you say to families, this probably is a less risky, better choice for your loved one to keep them safe and well to go into a nursing home? What does that look like?
Well, the main factor really is safety. And today, if you have a large supportive family and the family can all pitch in and help each other and not get resentful or fight or anything, and they can share the caregiving, that's the best option. But a lot of times families can't do that because adult children have to work. And if mom or dad has Alzheimer's and they've fallen 2 or 3 times in the last few months, it might not really be safe to keep them home without 24-hour care. Now, the cost of live-in 24-hour care and skilled nursing facilities is about the same. It's going to cost about $10,000 a month for a quality skilled nursing home. And a quality live-in situation where you have 2 or 3 caregivers doing actual living care where they can sleep at night, it's going to cost about the same. And I like that option much better. It's a very personal option. The caregivers, if they're good, get very close to mom and dad. They keep the family apprised of everything. They keep the nurse advocate or the care manager apprised. But caregivers aren't to be confused with being a patient advocate, because they're getting paid by their home care agency. And by the way, it's illegal in Illinois now to hire people under the table. And you always need to hire a quality home care organization like Open Arms, because you're bonded, you're insured, you are responsible for replacing caregivers if they can't go to work. The under the table ones that are probably not in this country legally, I've seen terrible things from under the table caregivers that you can get cheaper, but if they fall and hurt themselves, they can sue you. They can steal mom's jewelry. I've seen terrible things. Older people left in urine all night. Stuff.
Oh my gosh.
So
yeah, that's a topic in and of itself, but I appreciate your mentioning that. Liz, we do have a question from a viewer, so let's make sure we get to that. It says, the question is, during COVID, is doing a virtual tour of a facility enough?
I would just ask an awful lot of questions. Make yourself an Excel spreadsheet. You can do a virtual tour and then follow it up with other things. Search online questions to ask when looking at skilled nursing facilities, in addition to what I said. So
okay, I appreciate that. I mean, I think that's something that I know I've had friends that have been in a scenario that they're looking for a senior living community for their loved ones, and it's so difficult because the communities are doing the best that they can with virtual tours. They really are.
Yeah.
And their hands are tied too, right? They're trying to keep their residents safe, but it's difficult. It's very difficult it's stressful. COVID is stressful in and of itself, but when families need to assess a senior living community or a nursing home, doing a virtual tour, that's a challenge. So I think doing additional homework, having a plan, researching questions to ask, and having that plan ready when you do, when you talk to someone, is so vitally important.
Yeah.
Well, one of the questions I wanted to get to, and I don't think we're going to get to be able to talk about it because we're almost there, but nursing homes, as you said before, some part of the nursing home is skilled rehab, where people are going there, they've fallen, they have a surgery, and then because there's physical therapy, occupational therapy there, they rehab there to get stronger, and then they go home. And what we've been talking about today is really, when someone needs that long-term custodial care, that is covered that is not covered by Medicare, as you pointed out, that is covered either by private pay, people paying out of their pockets, and then the other option is Medicaid. Medicaid, and that's another whole different topic for a different day, is Medicaid is communities that accept Medicaid. There are fewer and fewer of those communities. And first, your loved one has to qualify for Medicaid to have that be an option. And if that's something where cost is a problem and you still feel that your loved one's not safe being home, then I would really urge the people that are listening to talk to an estate planning attorney, because they can really help assess if there's a way to, if your loved one can qualify for Medicaid. But those are the most heartbreaking stories in my experience. And I think if the bottom line I would say is that if you seek out professional help, either through a patient advocate like Teri, or a geriatric care manager or an estate planning attorney, those folks have the expertise to guide families in just the different scenarios that they face so they can make the best options.
Exactly.
We're out of time.
Okay. Well,
Teri, these times always fly by so quickly. It's flew by faster than I wanted it to, because there's so many other things that I know you could share to help folks. So would you be willing to come back if we...
Oh, yes. I would love to talk about what happens when you're short on money. And then
that's a really critical topic for so many people. Thank you so much.
Thank you. I'm so grateful to be here, and I love being here. So anything I can do,
for everything you do to help families.
Thank you.
Really appreciate it.
Okay.
All right. Bye now.
Bye-bye.
You too.